Okay, it's my pleasure to introduce Dr. Philip Smith, Assistant Professor of Pediatrics at the Boggs Center on Disability and Human Development at the Rutgers Medical School. Our first presenter is Dr. Smith, and he is going to be presenting on autism and co-occurring anxiety disorders, a hidden challenge in problem behavior. He brings deep expertise in positive behavior support and autism services, having delivered trainings across New York State and presented at conferences around the world. He is also a published author, including the book Positive Strategies for Students with Behavior Problems. Please join me in welcoming Dr. Philip Smith.
Thank you, Catherine. And let me pull up the slides so that we can go ahead and get started here. Trusting that everyone can see the presentation outline that we're sharing. We're going to launch into our discussion of autism and co-occurring anxiety disorders. Where we're going today, we're going to start out with an overview of autism and anxiety. We'll spend a little bit of time talking about some of the diagnostic challenges in terms that we encounter identifying anxiety disorders in individuals with autism. We'll move on from there to look at some of the treatment challenges that we encounter and discuss some strategies to address those difficulties. In conjunction with that, we'll spend a little bit of time talking about behavioral and community support strategies along with treatment. And along the way, we'll mix in some case illustrations. I want to start today's presentation off in a little bit different place than we usually do. I'd like to step back and have you think about at a personal level, what would your life be like if you wake up in the morning and you're getting ready for work and you have no idea what you're going to encounter when you get into work? Or if we're supporting a student or a youth and they're getting ready to go into school, they have no idea which one of these teachers they're going to encounter. And the reality is, the person that they're encountering is exactly the same person, but they just have uncertainty. And I think this is a concern when we think in terms of what the experience of people with autism would be like. Yeah, put ourselves in that position. We're missing out on, we don't have the social cues. And so we're just completely unsure what we're going to experience when we walk in the door in terms of that social encounter. Building on that, I want to really start out with that overview on anxiety and focus in on what anxiety really is. And anxiety is a complex phenomenon in the sense that it has two major components. We recognize anxiety very readily as being connected with the fight or flight mechanism. For some people, there's even a freeze response, but there's a rush of physical chemicals through the body that charge us once we see something threatening. And the charge of those chemicals can be highly adaptive and good if it's a genuine threat. They give us more strength to fight back or more energy to flee faster. The anxiety itself has two components. There is that physiological component that I just described, the chemicals that rush through our body, the adrenaline that hypes our body up and gives us the extra capacity. Along with that, there's a cognitive interpretation of what we saw that enables us to recognize the degree of threat that's being experienced. Most of the time in the world that we live in today, the anxiety threats don't come from that fierce animal that we looked at on the last slide. We're much more likely to encounter challenges, threats that relate to social factors. And so our anxiety is more likely to be triggered by encounters with people, social demands, or social situations. And the reality is that we now live in a culture where anxiety disorders are the most commonly diagnosed clinical disorder in terms of the population as a whole. We're not just talking about people with autism spectrum disorder. The broad array of anxiety disorders are the most frequently diagnosed category. And the concern is, are we overgeneralizing some of those socio-cultural threats and reacting to things that we shouldn't be interpreting as threatening? Um, Uh, Moving on to look at the challenges related to understanding anxiety in relationship to autism spectrum disorder. Uh, People with autism spectrum disorder encounter those situations and challenges in a much more intense way than the general population. Uh, they have more difficulty with social awareness and social comprehension. Without going back to all of the diagnostic criteria, social difficulty and challenges in forming social relationships are central to the diagnosis of autism spectrum disorder. In addition to weaknesses in their social understanding, people with autism frequently have weaknesses in social coping skills. And so when they encounter difficulty, stresses, challenges related to anxiety, being able to interact effectively with other people to mediate that anxiety is a weakness. In addition to that, verbal skills tend to be problematic for people with autism, and very frequently factors like a tendency to perseverate can complicate anxiety challenges. If somebody sees or encounters content that generates anxiety and the person then begins to perseverate on that stimulus or those phrases, they're going to escalate their level of anxiety rather than reducing their sensation and being able to cope with it more effectively. In addition to the social and language related difficulties associated with autism, people with autism also have neurosensory differences. They are more sensitive or less sensitive to certain kinds of sensory stimuli, and that increased or heightened sensitivity can frequently generate more physical reactions and make the person experience things at a physiological level that are difficult to cope with, and that can mimic or induce feelings of anxiety along with the social challenges. Um, when we look at anxiety disorders in general, we're looking at a broad category of clinical conditions. In summary, anxiety disorders are marked by extreme chronic anxiety. The condition impacts mood, it impacts thinking, it impacts the behaviors that people engage in, the activities that they seek out and choose, or the activities that they avoid. Um, by definition, to be considered an anxiety disorder, it has to undermine adaptive functioning. One of the things that's important to recognize is that anxiety disorders tend to grow progressively worse if they're not treated. This is an important distinction between the anxiety disorders and autism, because autism, by our understanding as a neurological disorder, doesn't grow progressively worse. People may have ups and downs over the course of their life cycle in terms of how they cope with some of the challenges, but the autism itself isn't expected to get worse. Uh, the other major impact that we see in anxiety disorders is that they spill into the behavioral realm. Anxiety disorders frequently underlie maladaptive behaviors. People will engage in problem behaviors in order to escape or avoid their anxiety. And this frequently generates a pattern that might be difficult to understand when people are trying to conduct a behavioral assessment. And if, as clinicians, we're talking to a behavior analyst, the tendency to have a behavior triggered by or influenced by anxiety frequently results in identifying the behavior as sensory motivated because the trigger for the behavior is internal. That's one of the factors that often leads to anxiety being identified as a hidden cause or a hidden factor in terms of triggering problem behavior. And so people intentionally misbehaving or getting in trouble so that they can stay at home, avoid going to work, or even miss out on activities that they would ordinarily enjoy. They may engage in behaviors to avoid those activities in order to avoid the anxiety that goes along with those behaviors, even though they enjoy the activity itself. Uh, the dynamic that we're looking at today is really important because we live in a setting where 40% of the adults that we encounter who have been diagnosed with autism are also diagnosed with co-occurring anxiety disorders. Even more significantly than that level of frequent occurrence, there are studies that demonstrate that up to 80% of people with autism exhibit behaviors that are associated with high levels of anxiety. And so we don't know the extent to which these behaviors represent undiagnosed anxiety disorders or people with autism just struggling with higher levels of anxiety than the general population encounters, but who are not diagnosed with an anxiety disorder. So anxiety is a critical issue, whether it's diagnosed as a disorder or just a general factor of life in the experience of people with autism. And so if we're treating someone with autism, chances are at least 4 out of 5 times anxiety is going to be an issue, whether it's a formally diagnosed disorder or something that the person is struggling with in their life. Uh, Making that differential diagnosis is challenging for a variety of reasons, however. How do we identify that anxiety disorder? Well, within the autism spectrum disorder, the difficulty communicating verbally can often impact participation in a clinical interview, the person's ability to answer questions. And if they're unable to tell you about that sense of anxiety or they miscommunicate, we may need to fall back on, rely on observing behavioral symptoms to make a diagnosis. Another challenge is that many times intense anxiety can generate or result in repetitive behaviors, things that appear to serve no function at all. Things like tapping a pencil, fiddling with or twisting and shredding a piece of paper or twisting on clothing and that sort of thing. And many of these symptoms can be confused with stereotypic behavior of autism. And so the question then becomes, are they part of autism or are they part of a co-occurring anxiety disorder? One of the things that I find really helpful, really important to focus on is if we see an escalation in these behaviors, it may be an indication that the person is experiencing a heightened level of anxiety and reflexively falling back on their stereotypic or repetitive behaviors as a way of coping with or trying to manage the stress that's associated with that anxiety. So we're looking at a complex set of issues here. And I want to look at a variety of ways that we can approach this to support folks with autism and anxiety. One of the things that I want to talk about is the benefits, the potential to look to how we can integrate strategies to address anxiety into behavior support plans. Can we incorporate that or make that part of the plan? Not just looking at the rewards, but can we incorporate the prompts to use coping skills and the teaching of coping skills into behavior support plans? And we also want to focus on adding specific anxiety related treatment for people with autism instead of being overly focused on thinking that we can solve all of the challenges for people with autism through ABA and the behavioral strategies. As well researched as these techniques are, as well justified as they are in the field, the concern is that we may not be providing treatment that helps the person address the more specific concerns related to anxiety, in addition to the behaviors that are targeted by the ABA strategies. Real quickly, I said we're going to sprinkle in some case examples. I'd like to mention a gentleman named Charlie that I saw in a clinic a number of years ago. He was a 40-year-old individual diagnosed with autism and a very mild intellectual disability. He'd made a very positive adjustment. He'd been living in a community-based group home, working in a grocery store for over 10 years. He had done extremely well there. He was very positively regarded as an employee. He was functioning well in the group home. He attended a self-advocacy training program and started to ask about getting a promotion and a pay increase. And so the store manager responded very positively to that and moved him inside the store to begin working on the bagging so that he could observe the cashier and learn how to use the register, and potentially they saw him having potential to become a cashier. Not long after he had started the new job, he started hesitating and resisting leaving the house. He wasn't going to work anymore. Although he loved going to work, he wasn't going to work. And then this expanded. He wasn't going out to do activities that he enjoyed. He didn't want to go to the movies with his friends. He didn't want to go out to eat, all things that he was doing on a regular basis. And so the team at the group home were concerned. Is Charlie depressed, or is there something going on that's generating this pattern of behavior? And they brought him into the clinic for assessment. On a thorough examination, what we discovered was that working as a bagger actually presented a variety of social challenges. People just aren't always happy. If you put too many items in the bag and it's too heavy, or you put the wrong combination of the things in the bag, or you have paper instead of plastic. And he was experiencing a lot of critical comments and uncomfortable feedback from people that he was working with. And he started being hesitant, reluctant to go to work. He expanded, he generalized that to not just going to work, but his trigger for anxiety became heading out the front door of the group home, which was impacting the unwillingness to go to other activities. And so he just was avoiding all of that by not going out. On research, we dug deep into his files. We had to pull things out of the archives because this was more than 10 years ago. But Charlie had actually been treated many years ago for an anxiety disorder. He had some history there. And so we recognized that his behavior, that staying home, being unwilling to go to work, et cetera, was not depression and lack of interest or lack of motivation, but it was anxiety that was driving that behavior. And so we worked with his treatment team and engaged him in a multifaceted treatment program where he started a cognitive behavior therapy program. He had sufficient verbal skills to engage in that uh, type of support. The behavior analyst started teaching him some relaxation skills, something that he had actually learned years and years ago, but wasn't needing anymore because he had uh, made so much progress and was coping well on a daily basis. And the psychiatrist started him on a very low dose of anti-anxiety medication short term. So this is, um, an illustration of difficult circumstances and not recognizing or difficulty recognizing anxiety as opposed to other factors underlying problem behavior and the emergence of clinical symptoms. Another factor that's often challenging when we support individuals with autism and some degree of disability is the impact that it has on their day-to-day functioning and the supports that we provide. Uh, when anxiety is mild, people can typically function at their best level. This is typical not just for people with disabilities, but for all of us. As our anxiety escalates, it frequently um, undermines our ability to perform at our best. And if people are overwhelmed by extreme anxiety, they may start to avoid triggers for anxiety. And so they might avoid tasks or seek to avoid situations that escalate anxiety. At the extreme level, somebody with very high anxiety may not be able to do things that would ordinarily be easy for them. The challenge is that many times in treatment programs, day programs, residential support programs, even community living services, this might be interpreted as oppositional behavior. If we look at somebody who's not performing a task, we ask them to do the task, they don't perform it. We know that they're able to. This might be interpreted as oppositional behavior. In many cases, however, it might be a manifestation of heightened anxiety and their efforts to avoid the challenge, the discomfort related to that anxiety. Um, I referenced all of those situations. Let's move on from it's really hard to figure out anxiety to what are some of the things that we can do to support people with anxiety. And so before we get into the clinical arena, um, creating environments where we provide extra structure and we add predictability. One of the biggest challenges that's associated with anxiety for people in general is uncertainty about what's going to happen next. And so the more that we can establish environments where people can anticipate what's going to happen next, what's expected of them, is a way of helping to minimize anxiety. If we can identify the things that trigger the anxiety, can we can we plan the day so that we minimize exposure to anxiety triggers? For people with autism spectrum, adding that environmental structure, helping to avoid anxiety triggers, all of that organizational thing is frequently supported more effectively by providing visual cues than verbal cues. This is not universal, but for many people with autism, the visual, even for verbal individuals with autism, the visual cues might be a more powerful mechanism to provide insight or connection. Other kinds of supports for anxiety. Can we help the person engage in management of the physical symptoms? Can we get them to do some exercise? Can we help them to do relaxation exercises like breathing, muscle contraction? And finally, addressing cognitive outlets, allow the person to journal where they have some means of recording their feelings and getting that out? Can we help them to focus on and uh, identify positive or relaxing thoughts? And we talk about something like journaling. It doesn't necessarily need to be a written journal. I've had nonverbal individuals with autism for whom we did a daily picture journal where there was a copy of a picture schedule, and they were able to uh, mark each activity on the picture schedule with some kind of a visual cue related to their feelings, whether it was a face, a sad face, a neutral face, an anxious face, as a way of giving them an outlet for their feelings, as well as enabling caregivers and support providers to recognize how they're feeling, what kind of day they've had, and that sort of thing. So that can be an extremely useful support outside of the clinical arena. Um, as we move into the clinical arena, it's really important to go back and recognize that anxiety is multidimensional. Remember that we talked about two components. We talked about the cognitive component, the person's thought process, and how they interpret the stimuli that they see, and how that relates to the trigger for the actual physiological changes. So there's the cognitive and the physical. And it's important that effective treatment, the most effective treatment, is going to address both levels of anxiety. And so at the cognitive level, cognitive behavioral therapy, um, especially cognitive behavioral therapy with exposure and response prevention, and we don't have time to do an in-depth outline on how to do cognitive behavioral therapy. But this is a research-supported technique that's highly beneficial for individuals with anxiety. And there's considerable research that shows that that using cognitive behavioral therapy or cognitive behavioral therapy in conjunction with medication generates better outcomes than the medication alone. One of the challenges for people with autism is that the CBT often is conducted verbally, and so we need people to have sufficient verbal skills to participate in some kind of interaction at that level. Uh, there are a handful of people that are starting to do some studies to explore the use of cognitive behavioral therapy with picture communication, but that's not a published and research-based system at this point in time. What cognitive behavioral therapy essentially involves is teaching the patient to identify the root of their fears, to recognize the perceived threat, where it's coming from, and then to logically analyze that challenge, and determine, should I really be reacting to it or not? Is there an alternate way that I should think about that? And what should I do at a very practical level instead of just going into panic and flight mode? Some other treatment options, we can look at coordinating clinical intervention with behavioral strategies using techniques like systematic desensitization. There's also eye movement desensitization and reprocessing. And there's some research that demonstrates the benefit of complementary activities like yoga and meditation in terms of helping to calm people down. Um, Transitioning into the most common, the most typical strategy to address the physical concerns of treatment is medication. And I want to reemphasize the importance of addressing both the cognitive and the physical, because many times for people with intellectual and developmental disabilities, we over-focus on the medication and don't adequately recognize the importance of addressing the cognitive component of their anxiety. Both the cognitive and the physical are critical elements. A quick overview on medications. The most common medications for anxiety are the selective serotonin reuptake inhibitors. The preliminary research on these medications suggests that insufficient serotonin is generating either depression or anxiety. These medications are used for both disorders, but are looked at or used in different dose levels. Um, these medications block reabsorbing the excess serotonin so that there's more serotonin available in the system. Another less frequently used category of medications, because it's a little more complex chemically and in terms of side effects, would be the serotonin norepinephrine reuptake inhibitors. And in each of these categories, there's a list of the common examples of those medications with both the technical and the public advertised name. What's going to be listed in the doctor's manual and what's going to be the over-the-counter name for these medications. Another category of medication are the benzodiazepines, and these medications are more typically used for short-term treatment or management of anxiety. For example, people who are going in for some kind of a medical procedure or have to have an MRI and they're claustrophobic about going into the machine. These medications are used for short-term management of anxiety rather than long-term treatment of anxiety disorders. And they relate more to specifically relaxation of the muscles and addressing the physical symptoms at that level. What I'd like to do is go through another illustration of a young man with autism who also was manifesting anxiety-related challenges that were triggering problem behaviors. And then once we finish up with looking at Kerry, we'll take some questions and answers and spend the rest of our time engaged in some more general discussion. Kerry was 19 years old. He was a tall young man with an athletic build. And so when he became agitated and upset and started throwing things around, he could do a lot of property damage. He didn't have aggressive behavior in the sense of being really looking to hurt people, but he was prone to injuring people when he had agitated outbursts of behavior that were not well regulated or not well controlled. Kerry was functionally nonverbal. He had a couple of single words, but was prone to use them in a repetitive manner as much or more than using them as a communication tool. At the time that we were working with him, he was learning to use PECS, but he had not established the capacity to use his picture exchange communication as a systematic communication tool. He was living with his home family. He was receiving supports in the home, and since he still had educational eligibility, was in a day program, a highly structured school where they were doing some ABA instruction and some work readiness. He exhibited a variety of challenging behaviors. But when I was called in to consult with this young man, I said, we need to focus in specifically on one target behavior. And so the initial target behavior was self-injury. It was self-injury because it was the priority behavior because of how severely and frequently he was engaging in this behavior. He had non-healing wounds on one of his hands and a lot of uh, scabbing and buildup of skin and scarring on the other hand. Um, the team had already attempted to conduct a functional behavior assessment, but just really couldn't figure out what was going on. There were some times where he started engaging in the behavior when he was given difficult work or doing things that they didn't think that he wanted to do. But there were many other incidents that just didn't fit the pattern for escape motivated behavior. And after careful observation, what we were finally able to recognize was that when Kerry was biting his hand, there were actually two different biting behaviors. In the one case, he would bite his hand very firmly. He would put one hand into his mouth and push it into his mouth almost as far as he could push it in. He would make loud vocalizations while the hand was in his mouth, and he was flapping the other arm. Typically, this kind of biting, the teeth weren't making much of an impact on the skin between the calluses on his hand and the pressure of his hand at the back of his mouth. There wasn't much force that was coming down. He wasn't breaking skin. He wasn't bleeding. The other type of biting, he would take just his front teeth and bite down on a piece of skin on the edge of his hand while he was pulling and pushing his hand in and out of his mouth. And this was the type of biting that generated the concerns about non-healing wounds and bleeding and that sort of thing. We then engaged the team in conducting functional behavior assessments of each of the two different behaviors. And what we found was that the biting where he put his hand into his mouth firmly, it was a method that is actually recommended in some self-protection strategies to break a bite hold. But instead of trying to pull your hand out of the mouth, push into it because that breaks the bite hold. Kerry was, in essence, breaking his own bite hold. He was doing this in situations where he was asked to do work that he didn't want to do. And so, along with that kind of biting behavior and flapping his arm and vocalizing. He wanted people to see what he was doing because this was his way of avoiding work, chores that he didn't want to do at home, or school tasks that he didn't want to have. There was some other factors that also influenced the behavior in a secondary way, as setting events, poor sleep, illnesses, ear infections, previous tasks that he didn't like to do, such as speech therapy, or other frustrations. The other hypothesis, where Kerry was biting and really tearing at the skin and causing bleeding, what the trigger had to do with feeling tense. There was some indication of stress and anxiety, and we had a variety of behavioral indicators of stress and anxiety. If he showed an escalation in his stereotypic behaviors like pacing, that was identified as him starting to escalate into a pattern of anxiety. When he engaged in this kind of behavior, one of two things happened. Either he would eventually space out and just get into his own little world where the pain wasn't noticeable, and he was escaping and avoiding any kind of sensation at all, or people would interrupt, talk to him in a calming manner, take him out for walks, and do some kind of break-related activity. And so, in this case, an escalation in feelings of anxiety was the trigger for the behavior, and calming or relaxation was part of the intervention. And so he really needed two different intervention plans for the escape-related behavior, easier tasks during difficult times of the day. The team introduced a PECS cards on his board where he could ask for breaks or ask for help, and he was taught to use those cards. He was given choices, systematic choices using picture selection about which tasks and activities he would do at what time during the day. They arranged the schedule so that he would alternate easy and hard tasks and receive better rewards for the harder tasks. And so that was all related to the escape motivation. For the sensory or anxiety related motivation, he was prompted to engage in relaxation exercises or activities at the first sign of that escalating tension. He was offered to go for walks or take breaks, some of the things that people were doing after he started having the anxiety. They would catch him with the escalating signs and take him out for short breaks um, uh, instead of waiting until after he started biting to do those kind of interventions. They developed a variety of other individual specific relaxation strategies, and they consulted with the psychiatrist regarding possible use of low doses of anti-anxiety medication to help alleviate those kind of behaviors. Long term, how can we adapt the environment to support more independent functioning? We worked on establishing a schedule that added more predictability and helped him with planning portions of his schedule. They developed a system where he would practice relaxation exercises and develop skills in those areas. They worked on developing a self-awareness system where he could identify how he was feeling and learn to associate certain kinds of feeling states with seeking out certain kinds of activities. And then longer term, there was exploration of adapted psychotherapy and social skills training to help him mediate and cope with some of the anxiety stressors in his life. Okay, so that finishes up the material that I outlined for our time. I recognize that we covered a lot of ground in a short amount of time, and so I'm anticipating that there would be some degree of questions and uncertainty. So let's open up the floor, and I don't know if anybody wants to moderate or if we just, I guess, if the moderator has questions that are already in the chat, let's address those and then open the floor up for folks who would like to present their questions.
Dr. Smith, thank you so much for this presentation. I'm going to have Ayeli help with sharing the questions that may be in the chat.
Hi everyone, my name is Ayala Kiswani. I'm the Inclusive Healthy Communities Coordinator. I'll be moderating the questions in the chat. So the first question we have is, how can family members and caregivers support someone experiencing anxiety-related behaviors?
Okay, well, I think there's two levels there. One would be if you're recognizing anxiety-related behaviors, you would want to seek out clinical assessment to determine whether there's a full-fledged anxiety disorder, and is there something more than that we can do besides just providing in-home supports. Along with that, though, finding activities that are relaxing or calming. Sometimes even the use of stereotypic behaviors may be relaxing or calming. And so allowing a person to engage in a low level of the self stimulation behavior for a short period of time may help to calm the anxiety. We don't want to let them do that for too long. And so we want to find a way to gradually transition them into a more constructive activity or engaging in something that is also a calming activity. This would vary tremendously from one person to the next, whether it might be exercise activities or breathing or relaxation exercises. For the young man in the Kerry example, he loved sound and noises, and but he had trouble following verbal directions to engage in breathing exercises for relaxation. So we found a slide whistle, those old things where you slide the handle up and down and you blow in it. And the beauty of that is that it only made the noise when he breathed in sync with how he was moving the slide handle up and down. And that created a calming pattern of breathing. I've had individuals that had, preoccupations with cleaning things up. And so one way to help them calm down might be to give them control over their environment. If we have a box of clothespins or something like that, and we dump it out on the table and let them pick it up, that gives them control over their environment and helps to alleviate the anxiety. So those are general strategies that we would need to individualize on a case-by-case basis. And so consulting with either providers, if the person is already receiving some type of services, or seeking out a clinical evaluation would also be an important supplement.
Thank you. The second question we have is, what are the findings to the causation on the increase of anxiety on a whole globally?
Well, it's hard to say what the findings are in terms of causation. What we've seen since COVID is there's been a tremendous increase in the frequency of diagnosis of anxiety disorders across the population. And, we can't say that this impacts people with autism differentially than the general population, but I think some of the sociocultural factors related to uncertainty due to the COVID diagnosis, other social factors due to the broad conflict areas that we see emerging in culture are factors that generate increased levels of anxiety in people. And the more often that somebody's encountering anxiety, the more likely they are to have excess anxiety. And then as the anxiety becomes excessive, it starts to interfere with adaptive functioning.
Okay, thank you so much for answering that question. What are your thoughts about low-level laser therapy to help with anxiety and behavioral challenges for a child with autism?
The laser therapy is not something that I've researched extensively. I think the important component of that would be to review the available techniques. I know that there are some research studies that have supported the use of deep brain electrical stimulation, not the traditional shock therapy, but stimulating certain parts of the brain to facilitate treatment intervention with treatment-resistant depression, and they're starting to explore that with anxiety disorders. And so I think that the benefits of that low-level laser therapy would be an impact, potential impact on physiological dimensions of the autism or the anxiety experience that an individual has. But again, I would hesitate to highly recommend or steer people away from those treatments because I'm not well versed in that area of research.
Thank you so much. That's all the questions we have for now.
That's everything that was in the chat. I guess in response to the chat or thoughts that you had during the course of the presentation, if folks would like to unmute and speak up and ask your questions, I'll be ready to enter into a dialogue with you on that.
Hello, everyone. My name is Christina Marte. I do have a question about the cognitive behavioral therapy. Um, you were stating that for, well, my son is 11, so for children that are not verbal, right now, that would not be an approach that they could use effectively. Is that what I was understanding?
Um, yeah, the current research and implementation methods for cognitive behavioral therapy really is using verbal interaction as a means of teaching the person to analyze thought patterns, recognize what's triggering the anxiety, and then altering how they might think about that. There are some professionals who are doing cutting edge, innovative work that are exploring efforts to use a picture exchange communication kind of method to try and have visual indicators and influence that interaction. But there is no research-based gold standard method for doing the cognitive behavioral therapy non-verbally. And so the likelihood of finding someone with that expertise, et cetera, would be uh, challenging.
We have another question in the chat. Somebody said there's a water-soluble supplement from Nanogenesis Labs being touted to help individuals with autism improve speech. Have you heard of that? It's called Mind Expander.
Um, I have not heard about that. Uh, my first reaction would be to be very cautious and hesitant. There have been a variety of strategies that were supposed to be kind of breakthrough innovations for people with autism. Facilitated communication was an example of one of those methods. There was a lot of hype around gluten-free diets. And I think there's no question that for some people with autism, nutrition and the impact at a nutritional level um, has some relationship to their autism symptoms. The reality, though, is that there tends to be a great deal of variability from one individual with autism to another. And so I would suspect that if there is some potential benefit in terms of these supplements influencing a person's cognitive functioning in a way that would enhance their ability to speak more effectively, et cetera, it would likely benefit some people and not others, and wouldn't be likely to be a universally effective solution because of the great deal of variability from one individual with autism to the next. And so I'd approach it very cautiously. What kind of research has been done? What kind of background evidence do they have? What are the risk factors of taking it? And be careful before you invest a great deal of money.
Thank you so much for your answer. We have another question. How can providers distinguish between anxiety-driven behaviors and behaviors that may attribute to autism itself?
That is an incredibly complex and powerful question. I could have done the whole presentation just on trying to answer that. Um, it really goes back to the level that there's so much overlap between anxiety disorder symptoms and autism symptoms. If we look at avoiding eye contact and difficulty forming relationships, we identify that as one of the central characteristics of autism. It's also a defining symptom for generalized anxiety disorder, social anxiety disorder, et cetera. And so I think at some level, many of the symptoms that we associate with autism probably have some component of anxiety that is driving that symptom. And so it's probably a combination of the autism and the anxiety. One of the things that would be useful at a practical and day-to-day level would be if we see fluctuations in the intensity of a behavior, and then look for patterns. Are there things that are happening when the behavior escalates to higher levels that might be stressful or problematic or challenging for the person? And to the extent that that's the case, we would want to associate that with anxiety-related concerns. Even if it has something to do with the autism, if the person has both autism and anxiety, then we need to address both of those factors. And so what's relaxing for a person with autism might be different than what's relaxing for a person who is neurotypical. So we need to provide relaxation or coping strategies that are autism informed, even when we're dealing with anxiety. But I think at a very practical level, looking for patterns of fluctuation in the behavior. If something is occurring on a consistent basis in non-stressful situations, that's much more likely to be related to the autism. If something is occurring in more isolated incidents, and we can see something in the setting, the environment, the social situation that points towards stress or challenge that the person might be experiencing, we would want to focus on the anxiety-related concerns.
Thank you so much for answering that question. Does anybody else have any other questions that they want to ask? There's another question. What about adults who are verbal and have been traumatized in group homes?
That's an important question. I think there's a couple of challenges there. Even when individuals are verbal, if there's limitations or difficulty in their capacity to make social judgments or understand social situations, that may make it more difficult for them to report on or talk about what happened. But anxiety is frequently associated with trauma, and so people with trauma experiences are more likely to have heightened levels of anxiety, and we would want to look at not just anxiety-related treatment, but trauma-informed treatment and care. And that extends into another specific area. The three major components of support in relationship to trauma intervention are how do we help the person feel more empowered? How do we help them feel safe? And how do we help them feel socially engaged? And so we would need to look at addressing those three areas of dynamics in terms of the support setting, and then making sure that we get diagnosis and treatment related to trauma disorder. And the fact that the person has verbal skills is we should look at as an asset or resource in engaging them in the treatment process.
All right, thank you so much, Dr. Phil Smith, for answering all of the questions. I'll pass it along to Catherine for the next presentation.
Okay.
Dr. Smith, do you want to say anything, final words? This was really enriching and gives us a lot to think about and take back to our work, certainly for me.
Um, I think just that the comment on one of those last questions, the interrelationship between anxiety and autism can be incredibly difficult to parcel out because, and that's why I started with the slide that asked us to look at the uncertainty of the person going into work and which kind of boss or which kind of teacher are they going to encounter. That type of uncertainty is so dramatically heightened in the lives of people with autism because of their difficulty with social understanding and perception. And so I think there's a great deal more research that needs to be done in terms of parceling out the relationship between anxiety symptoms and autism symptoms. But in the meantime, at a very practical level, we should have anxiety in the back of our mind whenever we're supporting or treating an individual with autism, especially if they're presenting challenging behaviors.
Yes, well, this has been a really informative presentation, and I just want to thank you for being part of our symposium today. Thank you so much.
You are welcome, and trust that the rest of you have a good idea. I'm not the one to address sharing the slides. I think the hosts and managers will take care of that. Um, Thank you for your attention and your time today, and trust that you'll enjoy the rest of the symposium.